Oops. Good afternoon, everybody. First, I want to thank you for the privilege to be part of your conference and to have a lecture here. Thank you. And my presentation will be about one problem we are solving in my center. It's a clinical problem of decision making between two modalities of treatment of acute patient with acute myocardial infarction with ST segment elevation. Next slide, please. In acute coronary syndrome, as you all know, back please. There's a close relationship between duration of coronary artery occlusion and the extent of myocardial necrosis. So the goal of the treatment is to restore the coronary perfusion as soon as possible. Usually it's performed by direct PCI, direct coronary intervention, or fibrinolysis. Cardiologists, they are collecting data and they count the contact to balloon time or door to balloon time. It's important for them. In Czech Republic, we have 10 million people inhabitants, and we do more than 5,000 coronary intervention for STMI, for ST elevation myocardial infarction. Next, please. You see the importance of the duration of ischemia and the extent of the myocardial and the mortality of the patient. Next slide, please. Acute CABG in this setting usually is considered only in patient with ongoing ischemia, with left main trunk stenosis, with post-infarction ventricular septal defect, acute ischemic mitral regurgitation because of papillary muscle rupture, or rupture of left ventricle, or anatomically unsuitable lesion for PCIs. There are some patients like that. Acute CABG, on the other hand, is a solution for patients who are coming later than 12 hours after the onset of the symptoms, where the PCI has documented not so good improvement in the results. We can offer, when we do acute CABG in STMI, we can offer early and complete revascularization, and in some papers they are documenting better survival in patients with acute coronary syndrome, especially with improved LV function, who were surgically operated in the acute phase of the infarction. Acutely operated patients, according to other study from USA, they have better 1-year survival and quality of life documented. Next slide, please. So acute CABG in STEMI offers more modalities, offers a variety of techniques depending on the condition of stability of patients. You can do it classically on pump with cardioplegic arrest, with cardioplegia of the heart. You can do it on the beating heart, on ECC. The heart is not working but beating, it's perfused. You can do controlled reperfusion after cross clamping by blood warm cardioplegia. You can do it off pump, and you can do it as a hybrid revascularization. Just do a mid cap Lima to LAD and then PCI to other vessels. Next, please. I want to share our gained experience from my department, which is this is the department in Charles University in Prague, which is located in the center of the city, where many old people are living and many infarctions occur, and the accessibility to the center is very good. So we catch the patient early after the infarction, and we can react on this. Next slide, please. So, from February 2008 to December 2012, we did in our department, more than 2,000 pure CABGs. 235 of them, it means 6.3% patients we operated in acute phase of STEMI, e.g. It means first 24 hours after the onset of symptoms. 35 of them were operated 6 hours before after the onset of the pain. So in the very early phase, where the gain of the operation is the most. Next. When we compare elective patient with CABG, with elective cardiac revascularization, and the acute STEMI patient, we can see that the age was the same. They were in the same percentage male, and the body mass index was the same. You see that the population is a little bit more obese than the normal population. But in the cohort of acute STEMI, there were more patients with triple vessel disease, with left main trunk stenosis. Ejection fraction was lower. They were less likely diabetics. They were less likely hypertensive, and smoker was the same. Next. It's one back, please. It's understandable that the STEMI patient, the acute patient, were more often hemodynamically unstable, almost 18% of them. Almost 13 patients of them had cardiogenic shock, entering the operation in cardiogenic shock. So really emergent situation, really disastrous situation. It corresponds with the KILIP classification at the admission. Next, please. The STEMI patient had more catecholamine support, inotropic support. They were ventilated in 7.4%, resuscitated 6.6%, and they had more often 28% of them had intra-aortic balloon pump. 2 patients were on the ventricular assist device. Ventricular assist device was implanted before the operation because of cardiogenic shock and failure. Next. Concerning the operative data operation, you see that we did more often in STEMI patients. It was surprising. More often the op cap surgery, off pump revascularization. When we do it on pump, the ECC time, extracorporeal circulation time, and the cross-clamp time were longer. We did the same number of bypasses in both groups, and we inserted more often the intra-aortic balloon pump during the operation. Next time. In hospital mortality, or respectively 30-day mortality in this acute cohort, were 8.1%, which is for normal CABG quite high. But for this cohort, we had in the elective patients less than 1% mortality, which is significantly highly significant statistically difference. We have to compare this number because it's not usual number. We have to compare it with the same patients. For example, same patient who were treated by PCI in acute STEMI. The mortality in all national registry in our country is 10%. I found one work from Hagel from Hanover. They deal with patients with acute STEMI, operated in acute STEMI. First 48 hours, it was a little bit another cohort of patients, and they had 20% of mortality. So mortality is higher, but it's because the patients are urgent, they are in bad shape. Next. Postoperative course was more difficult in those patients, in acute patients. They were longer in hospital. They had more often low cardiac output syndrome, treated low cardiac output syndrome, more often dialysis, and more often implanted intra-aortic balloon pump or ventricular assist device after the operation. Next. When we compare patients with or without cardiogenic shock, patients who are entering the operation in cardiogenic shocks with the non-shock patient, you see that there is a real difference. The patients, it's clearly understandable, the patients entering the operation in cardiogenic shock, half of them die. It's despite of our effort. It's we can compare data from shock trial, which with large cohort. There were similar patients entering another type of therapy. It was PCI. There were the same mortality. Okay. Last comparison we did, we compared the patients who were operated in the very early phase. They were on pump or revascularized before 6 hours after the onset of the symptoms, so very early phase of the myocardial infarction, with the patients operated later, and we didn't found any difference in the results in the hospital stay, strokes after the operation, dialysis, mortality, and so on. So there was no difference. Next. And we did the univariate mortality, univariate analysis for 30-day mortality, for risk factor of mortality of those patients of the all cohort, and we found that only the ejection fraction and the factors concerning the hemodynamic stability were significant. Next. And the last comparison was univariate analysis for MACE, major advance event, cardiac advance event after the operation. And you see that only ejection fraction and KILIP class at admission were significant difference. So next. So we conclude our observation and our study that acute CABG could be performed with relatively good results in patients with acute STEMI, first 24 hours in ST elevation infarction. When revascularization is performed within the 24 hours, only hemodynamic status or impaired ejection fraction was a risk factor. Next. And we expect, we hope that further improvement of results can be expected with more frequent use of mechanical cardiac support in those patients with cardiac shock before the operation. When we stabilize the patient on the VAD or ECMO inserted, we stabilize the patient and operate after that. Maybe we will improve our results. We failed to demonstrate any difference in early and mortality and MACE in patient operated on up to 6 hours and patient operated later after the onset of the syndrome. It's just my note, the further postponing of the surgery in the acute STEMI can improve statistics because after that you operate only the patient who survived the acute phase of the operation. But it's worse to operate early in the acute phase sometimes because you can save life of the patients who are not surviving the acute phase otherwise without help. So thank you for your attention.